public multimodal de-identified critical care data set. Well over 60,000 hospital stays in this data. Has structured EHR data all de-identified, has waveforms, chest x-rays, echocardiograms. To access this data, users need to be credentialed, which is going through this identity check, completing training and human research, and signing a data use agreement to say that they won't do unsavory things with the data. And this is now extensively used in health research. The photo here, this beautiful photo, was taken by Leo Selly, one of the doctors in our lab, who also works in the hospital where the data was collected, and this was on his shift. I can never remember whether it's sun coming up or sun going down. I think maybe sun going down, but he took it from the window of the hospital where Mimic is collected from. And it's used for research like this. This was a research project by people in our lab that looked at, we've known for a long time that the pulse oximeters, these little things you clip on your finger, they shine light into your skin, look at the reflection and use that to assess how well oxygenated your blood is. We've known for a long time that those are not, they don't treat everyone equally. People with dark skin, they're just less good at working out how much oxygen you have in your blood. This was a recent study using Mimic that demonstrated that as a result of the inaccuracy of pulse oximeters on people with dark skin, patients in the hospital were getting less adequate oxygen therapy. This is another study which was interesting, and I couldn't really believe, but seems to be true, that with the chest x-rays that we share in Mimic, AI is able to recognize patient race. So it does a pretty good job at predicting race in chest x-rays. And that's potentially problematic because it means that your algorithms are baking in race, whether or not you like that. Whether or not you want race to be baked into your algorithms, and potentially will lead to biased algorithms, people being treated differently based on race. There has been a subsequent paper that kind of looked at why this is possible. I think that it was found that it's not a physiological reason, that it's something to do with shortcut features within the the chest X-ray images themselves. As Pete mentioned, we do a lot of community interaction. We've been organizing hackathons and datathons for a long time, where we bring people together around data sets on PhysioNet and try and work on focused tasks. This photo here was, we were invited by the Society of Critical Care Medicine to organize a datathon in collaboration with their annual conference, and it was a big success, and that became an annual event for Society of Critical Care Medicine. So each year we get together with the society and run datathons. And Leo Selly, who I mentioned, is it feels like he's doing one of these each weekend somewhere around the world. I've been a few in London. And so just to give you some idea about the kind of scale and the growth of PhysioNet, last year we had 60,000 new users register on PhysioNet. Sorry, the plots are not very easy to see. But on the left there, 2025, we had around 60,000 new users. Around a third of those, so 20,000, were credentialed, going through this training, identity check process. A lot of that is manual at the moment. And so that is someone, an administrator in our lab, checking 20,000 applications from people. And it's a huge burden for the lab. And we're trying to we're continuously trying to work out how to scale that. We have users from many countries around the world. The biggest user base is in China, which is problematic, which I'll talk about in a moment. And the bottom right here is showing our estimate how many articles each year are referencing PhysioNet. Reference, is we don't know what a reference is really, what that means, but around 14,000 articles each in 2025 in some way cited either PhysioNet or one of the components that we share on PhysioNet, and we get that data from Dimensions AI. I think the numbers are kind of difficult to, are not very tangible sometimes. So But I know when I go to a conference in my area, I see people using Mimic and PhysioNet. So we just looked at a couple of AI for health conferences, the kind of things that I feel like I might attend, and we found that significant proportions of articles were using Mimic or EICU or some other data set that we've shared through PhysioNet. So I think that it makes me feel good in some way that this public health data has enabled global reuse, reproducible research. It's cool that people can share their Jupyter notebooks alongside their papers, and you can go off and reproduce and improve and check. There's increasing benchmarks, and we had presentations today on some of the benchmarks that are being created using datasets shared on PhysioNet. Lots of university courses use datasets from PhysioNet. So that's all cool. But when I think Pete, when we were chatting, I was chatting last night with Pete, and we talked about how it was cool that people were using Mimic, and then Pete said, I think you said something along the lines of, but is that really a good thing that everyone is using Mimic? And I think that's really heavy on my mind now. Is what we're doing to share data enabling trustworthy AI? Is it enabling meaningful AI? Is it enabling deployable AI? And I'm not sure the answer to that is yes. I think that we've done broadly we've enabled people to do some interesting things, but I'm not sure that all of those things are really taking us towards what we want, which is robust, deployable AI. And so we, as a group now, are thinking much more about this. I think the pandemic was kind of a stress test for a lot of the work that's being done around AI for health. Many of us knew people, or maybe even ourselves did, at the start of the pandemic, start thinking about kind of diverting some of our effort to doing research around COVID to try and predict or classify whether patients had COVID or predict outcomes of people with COVID. The UK Turing Centre, around a year, I think, after the start of COVID, looked at all these algorithms that people had published on and asked the question, are these algorithms sensible? Are they useful? And this article is a report based on the UK Turing Institute work. They said that their finding was that hundreds of AI tools had been built to catch COVID. None of them helped. And actually, they said probably some of them caused harm. And when they looked at what went wrong, they coined this term kind of Frankenstein data sets. They said people were using Frankenstein data sets. They were spliced together from multiple sources. People didn't have domain expertise often. They didn't understand the data they were splicing together. The data often contained duplicates. And as a result, the algorithms were essentially nonsense. They were being tested often on the same patients that they were trained on. They were using lots of shortcut features. So there were algorithms. So these were chest X-rays, and they were spliced together from different hospitals. And some chest X-rays were from hospitals with heavy caseloads. Really lots of COVID, lots of sick patients. There were other X-rays that were some of them were from children, from healthy patients, and the algorithms were learning to use the font, the text. There were text on these chest X-rays, giving information about the angle the X-ray was taken, giving information about maybe the type of patient, and the algorithms were doing a good job at predicting because they were reading the font, reading what was on the text, and then deciding what hospital this patient was in, and was it a heavy caseload hospital? Then probably that patient is maybe that patient has COVID, and that's not something that is useful. They were using the patient's position. So if the patient was lying down, they were probably more sick. Patients sitting up, then they're probably well enough to sit up or stand up. And the algorithms were just working out whether the patient was lying down or sitting down or standing up, and then using that as information about the risk of COVID. So the outcome of all this was people were wasting their time essentially. I think a bigger kind of example of the of misinformation, of poor infrastructure and data came from this company, Surgisphere. This was a company led by, I think, a vascular surgeon, Sapan Desai, on paper, very legitimate researcher, MD, PhD, I think at University of Chicago. He announced early on in the pandemic that he had a data set with hundreds of thousands of patients across hundreds of hospitals and created huge global interest. It didn't help that Sapan Desai was very media friendly. He was all over the news, telling people about his company, Surgisphere, and how they had all this data. For people who were in this area where we were sharing data, it was kind of strange to suddenly see someone you'd never heard of, with a lot of health data and a lot of COVID patients. And this data was used to publish very high impact articles in the Lancet, in the New England Journal of Medicine. And you can see them announcing the Lancet article on their website there. This is one of the papers that they published in the New England Journal. But then people started to question, well, what is this data set and why have we not heard about this data set? And it started to fall down. And both those papers were retracted both papers were retracted. And it was unclear whether the data had, existed. No one was ever able to see the data. There were people making requests to see the data, to validate it. No one saw that data. And ultimately, it was a big, it was a really high-profile, terrible event around data availability. The WHO had actually halted 2 clinical trials as a result of those papers being published. And when they were asked, did you see the Surgisphere data before you halted your trial, they said, no, we just saw the papers and we assumed those to be, true. So this, if you're interested in the gory details, is a kind of nice summary of the scandal. They say that this prompted calls for reviews of how science is conducted, published, and acted upon. And I think, if you ask the question, would that same thing happen today? I think maybe it would do. It should have been a turning point where we kind of thought about the way we were sharing data, thought about the way we were doing research. But this is an April article, April 2026, work by Gary Collins at University of Birmingham in collaboration with researchers in Australia, I think Queensland. They found some kind of synthetic fake health data on Kaggle, and then they looked at how that data was being used downstream. And they found that people were taking this data off Kaggle, even though there was no provenance to this data, it was probably not even real data, and they were publishing academic articles that were reporting these as important clinical findings. Some of the models actually have made it into clinical use, is my understanding. So we don't seem to be getting better at data sharing. I think these didn't just expose bad data; they exposed a lot of missing infrastructure in the way we do research. I think not having clear ways for not having good ways for establishing data provenance, not having good ways of evaluating whether there is leakage within algorithms, information leaks within algorithms when people are making predictions, not having kind of robust ways of evaluating the quality of algorithms, and not having clear governance around how we share and use health data. I think on top of this, I think we're seeing our scientific foundations being kind of under strain. Just some examples of this. This is a paper that's just been published that kind of is suggesting that people like us who share Mimic are doing, not necessarily a good thing in making data broadly available. So this study explored trends in publications that use public data sets, like MIMIC, like UK Biobank data. And you can see here the two plots. The left is MIMIC. The right is UK Biobank. The dates there, maybe you can't see, but this is a trend, temporal trend over time, number of publications on the y-axis and the temporal trend over time. You can see that when LLMs appeared on the scene, suddenly there's this big step change on MIMIC, where suddenly we're getting 1,000 more papers than we would expect in 2025. And UK Biobank the same. There's this big step change where suddenly people are using language models, presumably vibe coding papers. Our academic system likes papers very much, more than anything, rewards just people who publish papers. And so it's natural that this is what people will do. If we're telling people that their funding is dependent on publishing papers, and then we give people a tool to vibe code papers, then this is what you expect. So they call in this paper for measures to control access to open data, which is kind of interesting because in some ways it's the opposite of what many of us are thinking we need. There's also there was research by Stanford University a year or two back where they looked at, they said it looks like we're making great progress on clinical language models. So these are like ChatGPT, but they're for clinical information. And they looked at all of the clinical language models that have been published in the literature, and they found that almost entirely those clinical language models were using one data set, for training, and that was MIMIC. And so they called that the shaky foundations. By sharing MIMIC, we've enabled some research to be done, but actually we're just we're creating massive biases in work that's being done, because MIMIC is one Boston hospital, and so you're now creating a foundation model, a clinical language model that is just representative of patients who go through that Boston hospital. I think one kind of area that's interesting for me is, many public data sets are really poor representations of clinical reality. I think, I keep mentioning it, but there's this, the point yesterday about cleaning data, over cleaning. It's something with MIMIC we try not to do. We don't want to over clean, because your question, yeah. We don't want to over clean. We give people dirty data because that's closer to the kind of data that you'll need to deploy your models on. But it's not just around cleaning, it's around the structure. There's this study here that used MIMIC that looked at prediction studies using MIMIC. And they found that 40% of published AI models so they were doing prediction studies. 40% of those studies were using ICD codes as features. And in MIMIC, ICD codes are used for billing. They're assigned when the patient is being discharged. Someone goes through, looks at the patient's stay, and then says, okay, this patient has sepsis and this patient has diabetes. And so they were using information that's only available when the patient is discharged to do predictions. And often these are predicting in-hospital mortality. So, if your patient is being given an ICD code on discharge, you should not be using it to predict in-hospital mortality. And I feel, again, that's the fault of us as people sharing data. We need to make it much clearer how, we need to make it less easy to make this kind of mistake. It doesn't make sense, I don't think, to be, when the patient unfolds over time at the bedside, we should be giving data to people in a structure that is in some way representative of the fact that this is a timeline, a series of events that unfold, not mashing it all into a relational database and saying, here you go. Because then, of course, people will make mistakes with timing. It's also very difficult to make like-for-like comparison of model performance. So if I go to PubMed and I search for prediction of mortality MIMIC, I can bring out all the papers that are saying in the title that they're predicting mortality. I get several thousand papers. And again, we as academics like publishing papers, but what am I supposed to do with this information? I can't. If you ask me which is, I just want the best model. Which is the best model? I can't do that. I just have thousands of papers that have different patient selection, have different ways of defining outcome. There are many ways in which you can define in-hospital mortality or sepsis or anything else, and each one of these is doing that in a different way. And as a result, it's unclear what we're trying to compare between these different pieces of work. On top of this is kind of a brain dump of a couple of anxieties, but the area that we're operating in as people sharing data is changing. One question we're getting a lot now is, researchers want to use some kind of foundation model, some kind of, high capacity model. And most of those high capacity models are available through APIs. And so we're having this trusted relationship where I'm saying to you, you can use the data because we trust you. And then you're saying, I want to send this data, to this model that is available through an API, and we have no idea what's happening on that API. And it's a struggle for us. We actually don't know really how to deal with this right now. What we've tried to do, whether we say you can do or not, some of you are going to go and do that because that's what you want to do, and so it's a challenge. What we've tried to do is guide people towards using language models that have zero retention, for example, and that are through companies that we have some level of trust are going to be doing what they say they will do with the data. On top of that, the high capacity models can memorize data. So, if I'm giving you data and then you're sending it to an API that can learn the data, then what does that mean? That foundation model can now reproduce the data that we've shared with you securely. So again, it's a big issue, and I think membership attacks become much more a real threat when we're sharing some clinical information, sensitive clinical information about a patient, and then that model has also gone to the person's company website, and they've got the biography of that person, they've got the phone number, and they've got they've got some insurance details, maybe they know what kind of car the patient has, and maybe somewhere in our clinical data it's clear that this patient was in a car crash, and that's in the insurance data, and then you start being able to link together to have a picture of a patient that can start leaking personal information. We're also in understandably, regulation is becoming increasingly restrictive. I think around the world, I think certainly in the US, there's this new Department of Justice ruling in the US that came out last year, or is effective last year, that says that US patient data, bulk US patient data, mustn't be made available to countries of concern. And countries of concern are places like China, Russia, I think Iran, Venezuela. And I mentioned that our biggest user base for Mimic is in China. This means that we've had to shut off access to our biggest user base. People in China can no longer use Mimic. And that's not something we want. There's lots of good research being done in China, but that's what we're having to deal with. And then, is that a realistic thing to do? We do our best to identify research in China, but there's VPN and there's people getting around, our identity check. And so really, it's difficult to think that we can do this in a robust way. The NIH has also asked us to start becoming compliant with various NIST regulations, and we're researchers. We don't want to be going off and dealing with compliance with NIST regulations. The NIST 853 is one of the regulations that we've been told we need to meet, and so we've been given this spreadsheet with thousands of rows in it, and we need to go through and check off each one, saying that yes, our servers are protected from storms, and yes, we know when each of our team are logging into our computers, and it's like a huge amount of work, and So we're having to recruit an infrastructure engineer into our team to help deal with this. But again, I think it's an important thing to do, and it's a good thing to do, but it's increasing the pressure on us to share data. You're also seeing just the increasing value and interest in health data makes it a target. For us, UK Biobank is something that we look up to. It's I think a very well managed resource, and does not now allow download of data. Data exists within a trusted research environment, but there's somehow the data has found its way onto Alibaba. I think there's patient data being sold on Alibaba, and it's a real challenge. Knowing how, or working out how we enable research, and we do that in a way that is sensitive to patient privacy and protecting the data. It's not an easy thing. So again, this is kind of a brain dump, but I'm going to be telling you a little bit about some of the work that we're currently doing at MIT that is around infrastructure for responsible access to data, for model evaluation, and for deployable AI. I think Henry used the word commons. You mentioned the word commons when you were talking about what you wanted to see. I think kind of commons is a much nicer word of saying for infrastructure. I think what we need is a commons, common places to do these things. So one thing, all of the work, as Pete mentioned, all of the work we do is open source. So PhysioNet's code base, the code base that supports our repository, is available to everyone. You can go along now and you can set up your own PhysioNets for your own communities. So we've been working with people to create new PhysioNets to serve different communities. One of those is the University of Toronto has this AI initiative called TCARM. They have created this platform called Health Data Nexus, which is making data available to researchers in Canada, initially within a protected environment, but initially only to people at University of Toronto. You had to log in with your University of Toronto to be able to access data. But still, people could see what data sets were available, so it was good for findability of data sets, and helped establish provenance for data sets, even if you were someone outside the University of Toronto that couldn't access the data itself. We're working with groups in Korea, in Uganda, to create other platforms. And TCARM now is very well established and is doing very well. They're publishing some really interesting data sets. We also have, we now have federated search, so you can search on PhysioNet and find data sets in their platform and vice versa. And we're working on now integrated user profiles, so that if someone is trusted in University of Toronto, then we can use that as a trust marker when we're deciding whether or not we trust a user to access a data set like Mimic. We will be launching a benchmarking platform. So this is one way of enabling people to share data, but in a kind of a more secure way. So right now, people will publish a data set on PhysioNet, and there'll be some access restrictions, but ultimately, people can access the data itself. With benchmark data sets, people will publish data sets that never become public. They're only accessible through an API that's defined by the person sharing the data. So you can come and you can say, here's my data set. And the way that people interact with that data set is through this API. And using this benchmark platform, we hope to be organizing an annual challenge with the NIH. So that's something that is forthcoming. We're also trying to develop tools for better data set documentation. So Croissant is it's not a health metadata format, it's an AI metadata format. You may have come across it. So when you have your data, you can create a Croissant file that contains kind of very rich information about the data set, file level data. And you can use that to load your data set into PyTorch. It can be used for discovery. So when you're doing searches, I don't know if you've been to Google Datasets. When you go to Google Datasets and you search for data, often the results that come back are not very useful because it looks promising, and then when you actually look at the data itself, it doesn't contain the details you need. When people are creating these Croissant files, it allows kind of more granular searches and hopefully, easier to use machine learning data sets. So we worked on a project recently with the people who created Croissant to create Croissant Baker, which makes it easy for you to create these Croissant files, or easier for you to create these Croissant files for your data sets. And that now is a recommended tool by NeurIPS. So the datasets and evaluation track requires people to submit Croissant files alongside data or benchmarks. And so Croissant Baker is one of the tools that you can use to create that. We're also going to be following, and this is not necessarily a popular thing or a good thing for many people, but we are likely to be moving towards the UK Biobank approach of not allowing certain data sets to be downloaded by users. I know this was a pretty controversial change for people using UK Biobank. Some data, I think all data sets now for UK Biobank need to be analysed within trusted research environments. We have developed a prototype of the trusted research environment for PhysioNet, and we are currently testing it, and we are likely to be launching that in the near future, for better or for worse. Also, we've kind of, we believe that a lot of the value of data is in the annotations and in the expert annotations for the data. And so we've developed an API for PhysioNet, so a way of interacting computationally with PhysioNet for users to submit structured annotations for different data sets. So, lung segmentation masks, for example, or chest X-ray annotations, or textual annotations. Those are all supported by this new API that's been developed. We are at the moment choosing some pilot projects to demo this with, and the way it will work is we will announce a collection of annotations that we want, and then we will task the community with providing these annotations, and then we will build a collection of annotations that can then be used by people like you who are developing algorithms. We are working with the tripod. The people, I don't know if you're developing prediction models in healthcare, then when you submit to a journal or when you're doing your research, often you'll be required to follow some kind of checklist, like the tripod checklist here. This again is led by Gary Collins, University of Birmingham. So it's just a way of trying to make sure there's some kind of integrity in the studies that you do. Saying that when you're submitting your prediction model, that you identify the study as a prediction model in the title, and you provide study design, setting participants in your abstract, and so on. And the idea is this helps provide some consistency and quality within papers. Right now, there's nothing like that for code quality. What we find is people publish a paper. Sometimes they're asked to share their code too, but the code is extremely variable in quality and in structure. And so we are developing an extension for Tripod called Tripod Code, which is going to be developing a checklist. 1 minute left. How long has that been up? 1 minute. Okay. So we've just completed a systematic review of all of the code repositories that are associated with papers that have used Tripod. And we are now about to start a Delphi process with a set of checklist items for code quality. And if you're interested in being added to that Delphi list, then let me know and I'll add you to the list, and you'll be asked to provide your input on something like this checklist here, but for a code repository. And then the next step, we'll be doing the same for Tripod data. So we'll be looking at how we can encourage some consistency around and quality around data sharing. It was cool to see this mentioned earlier by Farah. We've been developing, I mentioned earlier that we squash data with Mimic into this relational database. You lose temporal aspects. We've been working on something called the Medical Event Data Standard, which is a super simple kind of AI-friendly data structure that is event-based, that we think will make it easier for people to use high-capacity modern machine learning models. What you find, the modern models are very, very good at dealing with sequences of text, And you can treat clinical data in the same way, sequences of clinical data. And also, we're kind of encouraging the idea of model portability. We recognize that data cannot be shared easily, but if people are putting data into the med structure within their individual, hospitals, institutions, and it's very easy to do with meds, it's just kind of squashing whatever data you have into a sequence for each patient, then even if you can't share that data, you can share your models so they can be retrained within each individual location. And there's a whole kind of ecosystem developing around building structured pre-processing steps. Right now we say huge amounts of heterogeneity or research degrees of freedom in the way that people pre-process their data. And we've come up with this, or not I say we, I have not, but a group has come up with pipelines for structuring those pre-processing steps so that you can share, your JSON file that defines tightly what kind of pre-processing you're doing with the data. So this is just kind of bring it together a bit. I think that we've shown we can build good models. There are many. XGBoost is an amazing model. What we want now is to just show that these models are kind of meaningful. So I think that we need more a commons for sharing data, for governing access, for deploying and evaluating models, and for trying to move towards systems that are more than just publishing papers, but that are thinking about that process of what's useful about this algorithm and what will make it deployable. And this is exciting for us. We will be holding an annual PhysioNet conference each year from next year. So we've got some planning to do. I was hoping to be able to give the date now, but I don't know the exact date. But I'd love it if you would join us at this conference. And what we want to do is get better at listening to what you want as the community, and then working together to try and deliver that. That's all I have to say. Thank you.
Do we have questions for Tom? Hyping.
Thank you, Tom, for the sharing. I want to ask two related questions. One is synthetic data, and secondly is the sharing of model that may have the capability of memorizing data, right? So because we know generative models are able to generate data. So do you think there should be, or is there already something like kind of classes of models, right? So for example, if I generate a model from Mimic, from some private data that cannot be shared, right? So if it's a SVM, probably I can share it freely. But if it's some highly sophisticated generative model, I think probably the big question mark, right? So that's the question. Then on the other hand, is the value and the feasibility of synthetic data that build in some way, because some data may use lots of real data in some way that there's a possibility of leaking information from the source data, but there are also probably some synthetic data that are probably robust. It may not be able to release, right? So how to do you see the synthetic data as a solution? Because if the data itself has no risk, then you can share it anywhere and people can use it more freely. But we do not see that happening, right? So there's nothing. No research is like I think ideal world probably you develop model on something like fully open. There's no concerns, and then we can test it privately on by a platform on their performance. And that probably can prevent many of the problem. But do you think that's feasible? Yeah. So basically, one is data, one is model. The question, yeah.
Yeah. Oh, yeah. So I've got a microphone. It's very. Those are great questions, and they're the kind of questions that we think a lot about, and we've not got solutions to. We have a lot of big tech companies using data sets on PhysioNet. And recently we were in discussion with one of those. They are wanting to train their models on all of the data on PhysioNet. And one of the questions we asked was, can you give us any kind of evidence that you're not memorizing, these patients, and that attacks to identify individuals are not, something we should be concerned about. And they basically said they were trying to work on, being able to demonstrate that, but they didn't have a way. They couldn't demonstrate it to us right now. And so right now we're asking industry, we're asking people to try and, prove to us or give us some kind of credible evidence that we shouldn't be, concerned, that they have some measures in place to prevent, the attacks we're worried about, and that to prevent memorization. But we don't have a solution to that. We want other people to kind of give us something that will make us confident about it. Initially, we were asking people, if you are training a model that, it is believed there is a risk of regurgitating the training data, we ask you to share that model on PhysioNet using the same data use agreement as the data it was trained on. So we host, for example, Google trained a model for chest x-rays, and they shared that model on PhysioNet. But it's not something we can kind of reliably reinforce. We don't really understand, which models are ones we need to worry about. And it's difficult to get the community to do what you want. It's difficult for us to say to tens of thousands of people that when you train a model, you've got to share that on PhysioNet. Everyone wants to share on Hugging Face. So if you go to Hugging Face, you'll find models that are trained on Mimic. And, we do takedown requests occasionally, but we've not had much success with that. And actually, it's getting more difficult for takedown requests to be successful with Kaggle, with Hugging Face, and so on. And the second question was about synthetic data. I like the idea of synthetic data. My wife is an economist, and she has said that that's always been a big thing in economics, that often you'll be given a synthetic data set, you train your model, and then you submit your model for the final results to the people who hold the data. I think it's very sensible. I don't see why that wouldn't be, something that would work. I think synthetic data is easier in some kind of discipline or in some modalities than others. But I like the idea of synthetic data. And MPJ Digital Health or Digital Medicine are actually they at the moment have they're about to have a new call for synthetic data papers. So I imagine there'll be some interesting things coming out of that.
Thank you. Further questions? Yes, please. Yes, please.
Oh, yeah. Thank you. Really, really good talk. I just kind of want to ask a little bit about de-identification and kind of anonymization. Like having spoken to NHS colleagues, like it's actually really like a non-trivial thing to remove patient identifiers from like this vast kind of treasure trove of documents and data they have. I don't know how it was done for Mimic, and like do you think that's the techniques that we use, for example, something like the Mimic Note data sets could be used moving forward? So like, do you think even like LLMs potentially have potential in kind of de-identification, for example?
Yeah, for sure. I think it's a great question. Again, it's something we spent a lot of my time at MIT has been around developing algorithms for de-identification. And I mean, actually, it's funny, I talk about open source. It's one thing that we haven't really open sourced for various reasons. It became very tightly coupled to the data sets we work on. And there were some concerns about kind of revealing too much about how we do de-identification. We still, pretty much every day, I think I've got to finish up this, this package and make it available to the public, and then I don't. Alistair Johnson, who started at MIT at the same time as me, and we worked very closely together on building Mimic, is now at Microsoft working on de-identification algorithms. And I continue to have kind of discussions with him about this. It is an incredibly difficult problem. It's a very difficult task in the US versus the UK. In the US, we there's regulation called Health Information Privacy and HIPAA Portability Act, and it defines some identifiers that you need to remove in order to be able to share data under this safe harbor approach. And so we've developed algorithms that will remove those identifiers and allows us to share data. In the UK, at least when I was paying attention, it was a much more difficult task, because if it was possible for anyone to link back from the data, the de-identified data, back to the original data source, it was not considered anonymized, and so you're not able to treat it as an anonymous data set, and so it's a much more difficult task. And I think data sharing in general is much more difficult in the UK than it is in the US. What was the other thing I was going to say? We use, I guess, in terms of de-identification, we have pattern matching, regular expressions. They're very good at removing certain types of PHI, structured protected health information, like a date. If a date looks like a date and it has some forward slashes in, or that's very easy for a pattern to identify and remove. But what you find is patterns are also very fragile, and so we combine that with machine learning algorithms. We use BERT, and then we also we scrape the web for news stories that look like they're related to patients, and then we link those to patients, and then those patients become VIPs. They do not appear in our data set. There was a patient who was hit by a baseball or a baseball bat at a game, and that patient does not appear in the data because it was that person was all over the news, and and people knew that they went to the hospital. So it's a really difficult task. It's very difficult to not over scrub. There are lots of words that look like they're sensitive information, they're not, and it's very easy to remove those. And we err on the side of removing. What else is there to say? Yeah.
Thank you. Cheers.
Perhaps time for one final question. Thank you.
Hi, Tom. Thank you for your talk. It was really great to see what you guys are working on. One question that I have is it's related to the data usage agreement and use of large language models on the MIMIC dataset. So that's something I've personally struggled with, and I'm curious, what's preventing PhysioNet from kind of deploying their own proprietary model or collaborating with an existing company with a proprietary model to kind of ensure that it's compliant with the regulations? Because I think right now, while the data usage agreement is necessary, I think it might be introducing some limitations regarding the democratization of the MIMIC data.
Yeah, I agree with you about that. I think that honestly, we're running in. So we're actually a very small team now. We're basically 4 researchers, supporting what is now a really big community. And so I think a lot of a lot of these issues just relate to us just not having time to be able to think about them properly. I would love it if you came to us and said, look, this is what I think you should do, and it would make our lives easier, to have a sensible solution that we've not been able to think about, and say, look, why don't you speak to OpenAI, or why don't you speak to Claude and say, let's come up with a MIMIC implementation. I think that that is certainly a possibility, and I think it would be a really cool thing to do, and we should talk about it.
Thank you all for your questions.